BPH is a condition, it's a benign condition, non-cancerous, and it's a condition where the prostate enlarges over time. And what happens is it really begins fairly early on in life, really in men's 30s, and they may not be symptomatic in that decade of their life. Very rarely men can become symptomatic at that younger age, but most men, as their prostate get enlarged, don't really become symptomatic until they're about 50, 60 years old. And if you look at BPH as a disease process, right, the prostate's enlarging and it's blocking the urethra or the way the urine comes out and pushing up on the bladder. If you look at the overall incidence of this disease, it affects about 15 million Americans. And so 15 million American men are affected by BPH. And if you look at statistically by age, 50% of men at the age 50 are affected and 80% of men at the age 80 are affected. So we always say about BPH, it's really not a matter of if you're going to get BPH as a man, it's a matter of when are you going to get BPH. The threshold for a normal sized prostate is generally around 25, 30 grams or cubic centimeters or less. As a man gets older and the prostate's larger than 30 grams, that's when we start to consider it mildly enlarged. So it continues to enlarge from there, and different men have different rates of growth of their prostate. So some may have prostates in the hundreds of grams, 200-300 gram sized prostates, like mega prostates. Some just maybe, say, on average enlarged BPH patients, somewhere between, say, 50 and 100 grams on average. And that probably is the most common BPH patient who presents to a urologist for deciding on a treatment option. In terms of what causes BPH and actually prostate health and reducing the chances of getting BPH, unfortunately, many of these things are not controllable. So genetics play a large factor. Men who have large prostates often have first-degree family members who have larger prostates as well. There are factors related to estrogen and testosterone imbalance. Whereas men get older, this imbalance in hormone can trigger more rapid growth of prostatic tissue. So that also can't necessarily be, utilized to affect the growth of your prostate. But certain healthy habits, so lower fat diets and exercise and activity, these tend to be more favorable in terms of these men have less chance of having a larger prostate. So as we get older, I would say overall more healthy activity can reduce that risk. Sexual activity can also reduce the chance of your prostate getting as enlarged, and also in certain studies has been associated with a lower risk of prostate cancer. So there are some things men can do to control their chances. Unfortunately, many of the things are predetermined. So as we get older, like I mentioned, it can be invariable that the prostate will get larger. So the main signs and symptoms of an enlarged prostate, or say how a man comes to find out that he probably has a large prostate, is usually that they notice a weak stream, right? So they start to go to the bathroom and their stream is not as strong as it was before. They often, during that stream, it's interrupted. So they start, stop, and they're not really completing empty. So they may not feel like their bladder is empty. And whenever they go to the bathroom, they often go to the bathroom more frequently. So they may go to the bathroom now, and then say a normal individual may be able to wait 3 or 4 hours because they feel completely empty. Whereas a man with BPH may present to their doctor and say, you know what, I'm going to the bathroom every hour or every 30 minutes because I'm not really emptying my bladder completely. And really the last most probably clinically important symptom to everybody is getting up at night. So men will come in and say, I used to get up once a night if I had a beer or a glass of wine, or I had a late glass of water with my medication. But now I'm getting up 2, 3, sometimes even more often than that. And that's when those symptoms have presented themselves enough to say, you know what, this person probably does have an enlarged prostate. BPH, when the prostate's enlarged, affects urination in a number of ways. One is it's a pure restrictive phenomena or growth that impinges upon the urethra. And the urethra is really the passageway of urine from the bladder out to the penis. So if there's something compressing on it, then that affects the strength of the stream. It affects men's, say, consistency of stream, so that's why they may start and stop. So really it's extrinsic pressure is one phenomena. It also can put pressure upwards onto the bladder. And if it puts pressure upwards on the bladder, there can be this sense of urgency, like I have to go to the bathroom right away, or there can be that sense of I'm not completely emptying my bladder. There's a last component of BPH that many people don't talk about, and that's an adrenergic effect, meaning there's an overactivity of certain receptors in the prostate and at the base of the bladder. So the bladder sits like this and the prostate right underneath it. And at the base of the bladder and within the prostate and along the lining of the urethra, you get an overexpression of certain receptors. Those receptors lead to overactivity of the prostate. So men will get what we call an irritation or an over-irritative symptoms of the prostate. So that can be sudden urgency, frequent urination. They go to drink a cup of coffee or spicy food, and all of a sudden their symptoms start to just be triggered by those extrinsic factors. So it may not be an anatomical compression of the urethra, but that may be actually a more nervous or nerve-related phenomenon that's occurring with BPH. So BPH really brings about symptoms in men a few different ways, and really we classify those symptoms as either being obstructive or irritative. And basically the prostate can do either things to really lead to these symptoms in men. When men come to a physician or a urologist in particular for diagnosis of BPH, there are really a number of things we do, and some of them are very simple. So some of them are just getting a basic history from the patient and seeing if these symptoms that they're having from their urinary tract actually fit the picture of BPH. Because many of these symptoms can overlap, as you can imagine, with a urinary tract infection or prostatitis or even sometimes rarely cancer. So some of these symptoms may overlap with different diseases. So the doctor really wants to assess in a basic history, are these symptoms consistent with BPH? The second, which sometimes patients, of course, will feel uncomfortable about, is a rectal exam. But the reality is a digital rectal exam, which is one of the oldest tools we have to evaluate the prostate, of course, is an easy way to figure out, is the prostate enlarged and what's the surface contour of the prostate. So by doing this physical exam, we can assess to say, is the prostate larger than a normal person that we would anticipate? By putting these two things together, we really can make a clinical diagnosis of if a man has BPH. There are further tests that we do, of course, down the road to really delineate, does the patient definitively have BPH and are the symptoms related? And they may be things involving a uroflow test where you measure how fast a man urinates. It can be an ultrasound to evaluate the size of the prostate or the effect on the bladder or how much urine is left in the bladder. Physicians may also order MRIs in certain situations of the prostate. Sometimes an MRI may help figure out the morphology of the prostate, which lobe is enlarged, is it a middle lobe problem, a lateral lobe problem, what's the shape and morphology of the prostate. Or the MRI can be used to sometimes exclude things like prostate cancer. So if your PSA is elevated, we may utilize that test or that hormone test to figure out, hey, let's also screen you for prostate cancer with a prostate MRI. So multiple different tests may be obtained, but those tests usually are not obtained until that first basic history, basic physical exam, where the urologist can figure out if you have BPH. The relationship between BPH and PSA, or prostate-specific antigen, is that PSA is a hormone that's normally released from prostate cells. So as the prostate gets larger, the PSA value in everybody should also coexistingly increase. And what we see is a natural progression of PSA rise with increasing prostate volume. The problem, however, is that prostate cancer also produces PSA levels, but typically prostate cancer will produce PSA levels far higher than a normal prostate gland for the same size. So what we say is when people say, do you have a normal PSA? Our interpretation of a normal PSA is usually related to the prostate gland size. So let's take, for example, somebody comes in with a 50-gram prostate, 50, and has a prostate PSA of around 3. But we might say that's normal because a laboratory would tell you anything under 4 is considered normal from a laboratory test, but that 3 is also normal for this size prostate. But if you start to get a test of, say, 8 or 10 for a prostate size of 50, then that's abnormally high for that size prostate. And that leads us to believe that PSA hormone might be being secreted from a prostate cancer, not from BPH. So there is an interaction, and PSA can normally be seen in men who have an enlarged prostate. And sometimes that PSA can fall in the abnormal level, meaning it can be abnormal on your laboratory test. It doesn't necessarily mean you have cancer. It could just mean you have an enlarged prostate. And the vast majority of individuals who have a high PSA just have a high PSA because their prostate is enlarged, or it may be inflamed. Prostatitis, for example, is a cause of that. So it doesn't necessarily indicate in everybody that a high PSA means you have prostate cancer. If I was first just diagnosed with BPH, the first thing I would do is speak to my physician about what those options are for treatment. What's important about treatment is when you decide a treatment option is for yourself really deciding what's going to be the course of your life. One is, how much do these symptoms really bother me? I think that's probably the most important question to ask yourself before you even ask a question of the physician. because if they don't really bother you, then you may not really need any treatment. And you may just be able to alter your symptoms with certain dietary adjustments or lifestyle changes. Maybe avoid caffeinated beverages, spicy foods, etc. Maybe make more routine trips to the bathroom. But if it's not really bothering you, you may not need a treatment. But if it starts to bother you and you're interested in getting treatment, then you have to consider to yourself, am I someone who wants to take medicine or not? So if you want to take medical therapy, there are always first-line medical therapy options that most patients have seen TV commercials for, etc., that are generally very effective in reducing symptoms. They may not be as effective as surgical or minimally invasive procedural options in reducing symptoms, but they will reduce symptoms in the vast majority of men and are effective with generally low side effects. They do have some side effects that patients should know about, and the vast majority of them obviously are available to look up online, but the most common ones are things like retrograde ejaculation, fatigue, dizziness or headaches, even breast enlargement with certain medications that they take, and decrease even erectile function with some medications. So these side effects should be known by patients before they start to take them. But some men don't mind the side effects, or maybe they already have those symptoms and they're not going to be bothered and medications will be okay. So if you're first diagnosed and you're in a situation where you want to get treated, but you're not ready to get a procedure, or you don't want to have something even more invasive like a surgery performed on yourself, then I'd first learn about what those medications are and what those side effects are. The only issue with these medications is if you're younger or if you're going to live a long time, then these medications often will wear out in their effect, meaning your prostate will probably grow and you will outgrow the effect of these medications. So when it comes to treatment options that are beyond medications, so what we classify as minimally invasive surgical therapies or surgery itself, so either of those options, like procedures that you're going to get done for your prostate, the most important thing to consider is consider all options. So really learn about all options. Most patients are unfortunately not often told that there may be 7 to 10 treatment options for a man with an enlarged prostate. And they can range from the most invasive to the least invasive. They can range from having something placed through your penis to nothing being placed through your penis. But I think the most important thing to do from a patient perspective is learn what all of those options are. It doesn't mean that you're a candidate for all those options. It just means that if you learn what all those options are, then you can ask intelligent questions to your physician and say, listen, is this an option for me? Why and why not? And what are the advantages and disadvantages of one treatment option versus another? So there are multiple classes of medications to treat an enlarged prostate, and really they can be broken down into hormonal medications or what we call relaxing medications. The alpha blockers, or the relaxing medications, are things like Flomax. Many patients have heard of that. Flomax, Rapaflo, Tamsulos, and Alphazos, all those are really the same class of medications. And what they do is they relax the urethra. So that passageway where urine comes through the prostate is relaxed by those medications. And when that passageway is relaxed, urine can float easier through the prostate. On average, men get about a 6-point reduction in their symptoms. So what does that mean, 6-point reduction? The average man can fill out a scale of their prostate symptoms and have a scale of no severity of 0 and a highest of 35. Anywhere they are on their scale, if you take all comers, the average reduction is somewhere between 6 and 8-point reduction when you take medical therapy like Flomax or these alpha blockers. There's a whole nother class of medication which are hormonal type therapies called 5-alpha reductase inhibitors. And these work by blocking a passageway in the body of conversion of testosterone into a stronger agent which causes prostatic growth. So if you block that pathway, then the prostate will start to shrink and get smaller over time. And it works to shrink the prostate. The problem with this medication is it takes a duration of time for it to work, and it's also reduction in symptoms is not in that 6 to 8-point scale. It's really in a 3 to 4-point scale. And you have to treat a lot of men with this medication, finasteride, to even really see the benefit for only a few men. And the reason why is because of the time it takes and because of the secondary effect of shrinking the prostate. So not just shrinking the prostate by itself will reduce the symptoms so significantly in many of these men. But in men who have very large glands, say glands over 80 grams, invariably urologists will place them on a hormone medication like finasteride to help assist in that shrinkage of the prostate gland. All of these medications, both classes of medications, including Cialis or Tadalafil, which is more recently approved for the treatment of BPH, and also works through a relaxation pathway, these medications may wear off over time. And so it varies by patient. Some men get put on these medications and they don't work at all. Some, they work for a duration of time and then they run out. And some, they work for life and they can just stay on them forever. So really, it's very individualized when a man chooses, hey, now it's time to have a procedure. It really is based on how much it's really interfering with their life, either the symptoms or the side effects from the medications. Not every patient has to start with medication. The standard therapy is when you see a physician, most patients first are prescribed medical therapy. And oftentimes the discussion in and around the side effects, because it's just a pill, are not really discussed at length. And so men will take medication for years and years, and they're really taking it, and they don't really know they had other options in that initial stage. But as the medication continues to wear off and they're having side effects, there are less invasive treatment options, both honestly offered in the field of interventional radiology and urology for these patients so that men can get a treatment option without having the side effects of these medications. In our practice, we have lots of advanced tools. I mean, we're fairly lucky because we have more, I would say, tools and tricks up our sleeve, if you will, to really target almost any prostate morphology, size, and really patient. I think that's really the key. There are lots of options to treat a man with an enlarged prostate. So, in our particular practice, whether it's treating patients with prostate artery embolization, aquablation, holmium laser, TURP or the classic rotor-rooter, microwave therapy, green light therapy, you name it. All the options are really on the table, and includes more recent novel therapies in the urologic space like UroLift and Resume therapy. So really all of these tools can be utilized in different ways. And I think the most important thing when you're taking a tool or a piece of medical equipment or medical device is the way to have the best outcomes is really pick the right patient for the right tool, or the right tool for the right patient. From a tool perspective, it's great. We have lots of tools, whether it's in my field of interventional radiology, and we have ultrasound guidance and x-ray guidance and MRI guidance to make sure we have everything in the right place when we do our procedures. We utilize all these tools to minimize the risk to patients so that it's as least invasive as possible. The most common questions I get in and around BPH are, am I going to have this forever? Does this affect my erectile function? That's probably 1 and 2. And then, is this associated with an increased risk of cancer? I'd say that's number 3. So the reality is, there's an unfortunate reality that BPH has an overlap with erectile dysfunction. As men get a larger prostate, a larger proportion of those men also suffer from erectile dysfunction. It doesn't mean that it's not treatable, and it doesn't mean that every patient who has erectile dysfunction, the cause is from BPH. It just means that there's an association between the two. So in our practice, for example, we have urologists who actually specialize just in men's health and erectile dysfunction. And there are lots of treatment options that they can look after and seek. Just because they have BPH doesn't mean that they can't also seek out those options for treatment. But that usually addresses that question most commonly. And some of the medications, unfortunately, for BPH also have the side effect of erectile dysfunction or ejaculatory side effects where they have retrograde ejaculation. So there's a lot of overlap in this space. In terms of cancer, there's no increased risk of cancer because you have an enlarged prostate that you're going to definitely have prostate cancer. Yes, there are men who have BPH who also have prostate cancer and vice versa. But that doesn't mean that because you have BPH, you are invariably going to get prostate cancer. So it's important for men to understand that as well. And then the am I going to have it forever question. Am I going to have this forever, and is my treatment going to last forever? That's probably the most common question I get asked also in and around BPH. And the reality is, no matter what treatment you get, whether it's the old school, most tried and tested rotor-rooter TURP surgery that's been around for 40, 50 years, whether it's that procedure or now the most minimally invasive treatment, say prostate artery embolization, the reality is you're still going to have prostatic parenchyma or prostate tissue. And even if it's shrunken, smaller, a lot's been removed, you are going to grow new prostatic tissue over time. So your body will grow new prostatic tissue unless you have your entire prostate removed. And it may not grow fast enough or at a rate where you become symptomatic. You may never even know that you're developing new tissue. But most treatment options are not for life, because many of these treatment options, especially if you have them when you're younger, either you may need to be repeated, may need an alternative treatment like medicine. It may come back, but you may need nothing at all, which is really the majority of men. But if men ask, am I going to grow new prostatic tissue? The answer is yes, because you're going to grow new cells, but you may not ever become symptomatic from that and may not even need treatment. Are there questions that patients don't ask that I would say you should ask? If you're seeing a physician, and you are looking, I'd say down the barrel of a treatment option, and whether it's medicine and just a pill, or it's the most invasive surgery you can imagine, asking about every option that's on the table, even if you're not a candidate for that option, and why you're not a candidate, it can be a very brief discussion. It can be one line, which says, you're not a candidate for this procedure because it's too invasive for you. Even if you get that one answer, it's very important for patients to understand that there are 8, 10, 12 options. A physician doesn't want to necessarily spend time over-explaining an option that they know a patient is not a candidate for, because it can lead to miseducation, it can lead to confusion, it can also lead to anxiety for patients, because then they'll hear about treatment options that they know, wow, I heard this from my doctor, but I'm kind of confused. I heard it amongst 10 options, and he didn't really spend any time. I forget, was I a candidate for this? And you don't want to create that environment with the patient. But if the patient goes into this discussion with the understanding that, listen, I want to hear all the options, but I really want you to tell me why this might be best for me. If a patient asks that, they're really going to get the most out of their physician. And I think physicians want to, it's in their nature to be able to describe all the options that are available, but they have to sometimes be led down this road by an open dialogue and a patient who wants to say, hey, tell me all the options and tell me why you believe this is the best option for me. And if there are other options, just tell me those too, but also tell me why they may not be as good. And then I think you've had an open dialogue with your provider or physician, and you'll really get the most out of your healthcare visit.